Brian Stanton here with ACEP Frontline, and today we are going to join one of our favorite guests and the person who's probably got one of the most influential and knowledgeable voices in the RCM space, and that's Dr. Jason Adler. And we've heard from him before on our documentation and trends, successes, and pitfalls of emergency physicians, especially when we had the significant change in the documentation a few years ago. Now we're going to go into the downcodes and denials, some of the favorite games that are being played by insurers and payers out there. We dive into this, as he mentions, a 400-level course with regard to the topic and content, but also very important with regard to how our paychecks happen, and the fights that are taking place, especially on the ACEP side and between states and organizations with the government and other payers. So we're joining Dr. Jason Adler with Downcodes and Denials.
Today we're going to talk about winning the payer battle. We're going to focus on downcodes, denials, some of the behaviors that the insurance companies are doing within emergency medicine. And emergency medicine, historically, we innovate, we evolve, we adapt. It is definitely true that United Healthcare, Blue Cross, Aetna, Anthem, they're big organizations, and they are very effective at accomplishing their goals. And at the same time, we, emergency medicine, have an adaptive strategy that we will have through this conversation about how to focus on moving forward in a positive direction, and of course, offer some effective techniques to overcome some of what is up against us. Just some brief objectives here. Outline some common tactics used by payers to delay prompt payment, to highlight recent examples of payers' coding policy affecting reimbursement, and then really focus on the strategic angle. We're going to get a little bit tactical. Answer the following question: what can I do as a group leader to mitigate some of these policies that are forced upon emergency medicine, where it's a diagnosis list, whether it's an auto downcode, whether it's a denial, whether it's a modification of payment? What can I do as a clinician? What could I do as a group leader? Because at a conference like this, and I wanted to offer special acknowledgement and thank you to Ricky and Becca for putting this conference together. This is now the fourth year we've been doing this together, and this is a 400-level conference. Highly sophisticated people. You could, from the questions that are being asked earlier today, so far, you could tell there's a really strong engagement. There's a strong bench of expertise. So we can make this a dynamic interaction as well, and thank you to everybody. Before we get into the downcode and the denial discussion, we do have some breaking news. On Halloween, 6 p.m., CMS dropped the final rule. Does anybody not know that, or we know that happened, right? And it's not uncommon for CMS to provide these significant updates either the Friday before the 4th of July, the Friday before the Thanksgiving. On this time, it was Halloween. And it really makes the weekend a lot more fun as we got there. We started going through this around 8:30 p.m. There's a lot of really good information. Some of you may have heard that this is not the best final rule that we've had, and I want to offer a positive and optimistic look, because there actually is a lot of good stuff here. Yes, there's an efficiency adjustment, negative 2.5%, focusing on procedures. That is part of the administration's agenda, specifically RFK, focusing on the time requirements related to some of the procedures that are done. And that's a part of the RVU. Just to give an anecdotal example, a nursemaid elbow has an inter-service time of how long would you estimate a nursemaid elbow takes to reduce? Can someone just raise their hand and throw out a number of minutes?
7 seconds.
Yeah, well, the current valuation of the amount of time for a nursemaid elbow is 20 minutes. Some of the 20 minutes. A cholecystectomy laparoscopically is about 120 minutes. So that was sort of the partial intent to correct of some of the procedures that exist may be slightly overvalued. There's a perception that that might be the case. And the efficiency adjustment is focused on correcting that. There's some other downward adjustments for practice expense RVUs, for facility-based providers. But we've been through a period of 5 to 7 years where we've seen a downward adjustment of the conversion factor. And now for 2026, effective January 1 of the new year, the conversion factor is going up. Let's slow down for a minute. The conversion factor is going up. This is a big deal and hasn't been discussed enough. If you're in an APM, it's 3.77% at $33.57. And if you're in a non-APM, 3.26% at $33.40. There's a lot of messaging that's negative, but that really is a huge part of the story. So how do we get that? If we're going to focus on the non-APM clinician or practice group, you've got the previous conversion factor at $32.34. There's a QPP update that's 0.25%. You've got an additional budget neutrality component of 0.49. And then because of the OBBA, there's a statutory 2.5% increase, leading to that new CF of $33.40. So that really is the story. It's just a few days after this was released. This document is around 2,700 pages. It takes some time to go through. Some specialty societies and organized medicine has made some messages out there and pushed things out that mentioned this is a problem, this is bad for this reason or that. It takes time. It takes time to go through, it takes time to understand and digest. What I'm about to show you has not been shown before, and there are a lot of the public messaging I've seen that really focus on the practice expense facility-based RVUs that are downwards 20 to 30%, but that's a very, very small percent of the emergency physicians' work RVUs. This is what matters. This is what matters. The most common codes in emergency medicine, most RVUs in a typical practice, about 90%, 85 to 90% of all RVUs will come from your levels 1 through 5. The most common codes are the levels 4 and 5, and both of those have positive adjustments for the upcoming year. So we don't want to lose the forest through the trees and looking at the practice expense facility-based RVU for a particular code when the net impact is actually neutral to slightly positive depending on a few variables that exist. Let's talk about the insurance companies, and we're going to do it in a positive way. We're going to be optimistic, and we're going to have a good time. Some historical precedent. Believe it or not, there was a time where the transaction between a billing office and the insurance company and the clinical group was very seamless. You would submit a claim, you would receive payment. It would be a frictionless experience, and it was efficient, and it was balanced. We are seeing a growing trend, and I try to put that gently. It's a slightly growing trend, more like a logarithmic curve, like an S-shaped curve. It's a trend of delayed and denied payments. And one of the key take-homes from this section is that what we are identifying are pervasive. They're nationwide. It's not just emergency medicine. As mentioned earlier, the insurance companies and payers are very focused on doing what they do best, which is more favoring towards the premiums than it is the paying. But that said, we're seeing an increased pattern of escalations throughout the industry. And it used to be very seamless and frictionless. And the payment was very prompt. It's very prompt, with no disruptions at all or minimal disruptions at all. I'm going to focus on the prepayment process because that's really where there's a lot of opportunity. The post-payment reviews and things like that, that's mostly governmental, specifically Medicare. They don't do as much prepayment refusals, but when this occurs, the prepayment side, there's often no legitimate basis for withholding payment. There could be a full withholding, it could be partial withholding. The behavior that we're seeing is highly varied and all over the place, meaning distribution-wise. So maybe you submit a claim for level 5 and you're told this doesn't meet medical necessity, and then the claim gets put on hold. Maybe they say, okay, it's level 5, but then pay you less than the contracted rate. Maybe they say, we disagree, it's level 4, here's the value, or they'll say, we disagree, it's level 4, and do nothing. Part of this conversation is just being aware, understanding your data, having an idea of what the patterns exist, and having that good relationship with the billing office to understand what's going on with my team, what's going on with our book, because there's a lot of behavior that's done that's under the radar and takes work to identify. And we're also going to talk about some strategic approach for the clinician as well. We talked about a balanced and symmetrical process that's now unbalanced and asymmetric. The implications are significant. You're talking about delaying AR, delayed payments or no payments, and then the higher cost of practices. I'll go back to the university job, and you've got a large billing office. It's a multi-specialty practice plan. I work at a quaternary medical center, and you've got all the specialties that exist. If a patient comes in, this is a recent case, oh, I got hit in the face. Yeah, if someone gets hit in the face and the bones aren't in the right spot, you have to look at a chart and identify, is this OMFS? Is this plastic surgery? Is this ENT? Oh, it's a Thursday at 2 p.m. It's plastics. Got it. Great. We got a lot of resources. That's wonderful. But the central billing office is responsible for managing all these different specialties. So in one respect, maybe the emergency medicine claim may not be the highest priority, and I believe that their intent is to make it that way. But on another side is There's a lot of time and effort that goes into fighting these denials. You meet with, for example, a large commercial payer. We recently had one of these meetings with them about a patient that had multiple facial fractures, and there was another patient that had a mechanical fall with a ruptured spleen. And we have like conversations with a payer saying, this is like a threat to life or limb. And it's like, no, not really. It's just like an exacerbation of a chronic condition. It's like, oh my God, this guy was gonna die. Like, there's a reason you go right to the operating room. Oh my, like, this is really important stuff. Patient had pericarditis, that's bad. There's a reason they admitted it. Well, actually, it was the inpatient team that did the admission, not the emergency physician. It's like, are we talking about this? Like, these are conversations that occur, and they are labor intensive. How many people from the billing office were on the line? How many people from the payer side were on the line? How many physicians did we bring to the call to advocate for the work performed? So that asymmetry favors the payers. We talked about modifying the payments, we talked about downcode, we talked about denials. Oftentimes it's not uncommon to we're just gonna ask, oh, we're not saying we don't totally disagree, we just wanna understand. We just wanna understand, this is the payer speaking. Can you just send us additional records? You send a claim in and boom, within 4 milliseconds, like a Google search, you get an immediate, oh, we just want additional records. So now you gotta print them out, now you gotta send them over. The burden of time and labor is put on the billing office or the clinical practice, and that's a lot of time and effort that's very asymmetrical. It's an administrative burden, it's timely, it's expensive. And we know that the payers are using algorithms. Just to refresh the conversation, this is a highly sophisticated audience, but when these events occur, the payers aren't looking at your charts. You know how we know that? Because they don't get the charts. They get a form that has your demographic, a CPT code, and a DIAC code. And based on that, they're saying, nope, we need more information. How do we know the information wasn't sufficient? There's an algorithm in play. And maybe when you send it, maybe sometimes they'll take a look. We want to be nice to them. They're probably good people. And the advocacy efforts are underway. Here you've got a letter from the American Medical Association to Cigna. This was about a modifier 25 in the outpatient office visit codes. And the real conversation is just to show that it's not just emergency medicine, it's multi-specialties. And on this next slide, you have all the medical specialties that signed on to these letters. There's a lot of grassroots advocacy efforts. Your state college, the Colorado chapter of ACEP is actively engaged in these things in coordination with national ACEP. There's a tracker at National ACEP of all the payer behavior issues that is very tightly managed and followed, and we would encourage you to send that information in so that we can work, so that ACEP can work on behalf of the specialty for all of us. So there's little payer resources used, there's high provider resources used, it's just asymmetric and high burden. And then you gotta do it at the right time, you gotta send it to the right place, maybe you send it to the address shifts, which can occur, and the payer meetings is just very, very cumbersome. The EOBs that come in, or the EMITs, are like very, very vague. It just says, like, we just have a question. I just want to understand. I just want to, help me out here. C0150 is United Healthcare, that's a request for additional information. They just ask for medical records. Just, can you send us more information? And it delays the payment process. But the correspondents, you notice, don't use the language denial. They don't use the language denial. It's just, we want to be helpful. And then the way you have to react to that is like, oh, let me get this like letter, print something out, send something over, do it electronically. I'm just sharing that it's very asymmetric and cumbersome. So on the prepayment side, you've got reviews that are held. It's complicated and time-consuming. It's unbalanced. It's inefficient. It's not healthy. A patient that has a ruptured spleen that goes to the OR, why are we talking about a level 5 chart? And notice how like the surgery's paid, facility's paid. Sometimes it feels like the EMTALA badge is held against you, and we wear that badge on our sleeves, and everyone in this room knows through your training that we are all here for the right reasons, do the right thing. We are just taking care of patients. There is a lot to be proud of, and it's unfortunate that some payers are using algorithms to inappropriately deny, delay, or not necessarily always pay. And it's a heavy administrative burden. A lot of the behavior are related to diagnosis lists. Has anyone heard of these diagnosis lists? Yeah, a little bit. Yeah, it all started with, well, I don't want to say it all started with, but Lane is the one most commonly discussed. It's the Lane analysis that actually wasn't too long ago. It was around 2019 that list was created, and the contracting agency was Mercer. There's McClellan behind it. The audience of this analysis was to identify patients that came to the emergency department who could potentially be seen in an outpatient office visit. That was, the audience was for Medicaid and Medicaid and insurance company leadership to help determine where patients should go. And they identified diagnoses. There's about 700 on that diagnosis list, though in our current environment, there are some with 1,000, 1,500 and more diagnoses that are either allowed or be included or not allowed to be excluded that determine how a payer may respond to this. But Lane is often frequently referenced. And they were really trying to focus on cost control, right patient, right place, right time. And that's one that is just most commonly referenced. And I know with this group, we are all familiar with a lot of this information already. You don't need me to tell you that patients come in for the right reasons and they need resources, and emergency medicine is a safety net of US healthcare. There actually are academic journal articles out there. This was predating the Lane diagnosis. This particular study looked at the Anthem insurance policy that predated Lane, looked at a huge swath of visits and identified that 1 out of every 6 patients who came to the emergency department may be denied coverage based on that current policy. That was from 2018. And you can even go back to the Raven study in 2013. This was a really high-powered study that looked at the relationship between the chief complaint and the final diagnosis and the concordance between the two. This was done, the previous study, Jesse, you were involved with the previous study, right? Yeah, we have one of the authors here. You could talk more to it than I can, but thank you for your work. It was outstanding. The Raven study was also important, looking at the beginning and the end, finding no concordance. The fascinating part, again, is similar, is that nearly 90% of visits of those chief complaints, 11% needed immediate care, and over 12.5% either got admitted or went straight to the OR. It's a pretty big number of patients. There's a study from Kaiser that looked at the baseline denial rates. I just wanted to give some raw data from publicly available sources here, just showing that 1 out of every 5 claims are denied. In this analysis, they identified a lot of demographics. There's a lot behind here, but they identified the carriers that were most involved with this type of behavior. And then I'll just shift over to some individual specific policies. I want to make up some time for us today, but there's just a general pervasive pattern of either diagnosis lists being deployed, automatic downcoding, potential denials, delayed in payments, and it's not just one payer, it's multiple payers. It's not just one state, it's many states. It's not just emergency medicine, it's the house of medicine. And I said I would be optimistic, and we are, because there are things that we can do to move this thing forward, both at the clinical level and at the group level. This is a policy from Blue Cross Blue Shield in Texas that they were looking at prepayment and downcodes. Horizon Blue Cross Blue Shield New Jersey actually has garnered a lot of news. That's set to go into effect not too long from now. I'm sorry, that was this past year. This uses a diagnosis list similar to the Lane list, and the way this policy is written, if your first 3 diagnoses are on the list, it goes to there. If you have less than 3 diagnoses and any of them are on the list, there. So there are, and I know there's been a lot of advocacy efforts on this policy specifically. We met with the medical director of them, and they were like, well, there's actually, if you had, yeah, and it was a very healthy meeting that was time-consuming and felt somewhat asymmetric. Blue Cross Blue Shield Massachusetts, you got Horizon Blue Cross Blue Shield. This has garnered a lot of press as well. The interesting thing here is they are requesting medical records and using third parties to help their formula and their algorithms. Colorado Aetna. Aetna seems to be really jumping into the, is anyone experiencing that? Yeah, Aetna, I wanted to be very site-specific. Colorado Aetna, in this policy is July 2024. It's diagnosed code-based, automatic downcodes, lower levels. They just pay the lower level. Another one is Anthem in Colorado with the SIU. Has anyone heard about the SIU? It's the Special Investigation Unit. You see these letters from the SIU? It has a badge. It's a Special Investigation Unit. If this goes to a clinic, it's like pretty, I'd be nervous. Yeah, and it's literally like a Disney World badge. Like, it's not really it's just an emblem. It could be emoji for all you know. Like, it's just a badge, and it says special investigation, and you're like, oh my gosh, I'm being invested. That sounds bad. That is Anthem of Colorado. They are doing prepayment reviews and comparing you against your peers. Sometimes those peers aren't even in the specialty. There's just a lot of stuff out there. And then, of course, just for visibility and sharing, it's not uncommon to use third-party vendors using some form of artificial intelligence to support the end goal of reducing claims. Highmark 2025, this has garnered a lot of attention recently because they are telling you they're using the low acuity non-emergent diagnosis list. This is coming out over, this is October 2025. In the policy manual, it's very clear what they intend on doing. Anthem, California, there's just a lot of examples. Just wanted to share a few of them with you today. Yes?
So like, this is why it's so important to have the prudent layperson standard in place, state by state at a federal level. But like, how does that protect us from these kind of assaults from the payers? Can you talk a little bit about that?
Yeah, and the prudent layperson standard, EMTALA is a treatment standard of we're going to take care of patients. We're not doing wallet biopsies, no matter what they come from or where. EMTALA is a treatment standard, and the prudent layperson standard is a payment standard. Introduced by Senator Ben Cardin from the great state of Maryland, where they do crabs and football quite well. And your question is, how does that come into play? It comes into play like a lot. And you notice why some of the language on these policies don't necessarily say denial. They're just asking the question or wanting to have a discussion. And it's not always a direct denial. It's like, well, we disagree and we could have a conversation about that. I want to go through this next section about how we could sail through some of these audits from the clinical level upward to the leadership level. And hopefully we'll answer some of your questions and we can go back to it after that. This is such a great conference, by the way. I just always enjoy coming out to Colorado and seeing everyone. There's a lot of familiar faces. Again, Ricky and Becca do a fantastic job. So from the clinician's lens, there are a few strategies that we could focus on. And it really goes back to the documentation guidelines and our documentation. Now, we know that leadership has a central role in this. The billing office has a central role in this. But what can we do if we're talking to our colleagues about how to maybe mitigate or offer some defense on the back end? We know the key documentation elements related to the medical decision-making grid are quite important. We can go through them very briefly. The differential diagnosis, comorbidities are in the complexity section. You've got the data section of your external record review and your independent historian. I want to slow down for a second. And by the way, the data section is very quantitative. Very quantitative. You could have a robust conversation as whether a patient with a ruptured spleen has a life-threatening condition or whether it's just a complicated problem. But there's subjectivity there in some people's minds. But if you have a conversation with the consultant and document that, or if you perform an independent interpretation and document that, that's a little less subjective. That's pretty quantitative by nature. So your data section, specifically the management discussions, your independent interpretations, will be highly supportive of the work that you do in the audit. If there is I shouldn't say audit, in a review or questioning what's being performed. And then, of course, consideration of hospitalization as well. And the new guidelines, I know they're not really new anymore. It's 2023. That feels like 20 years ago. Have really good language, a nice quiver to the arrow of the prudent layperson standard and to the work that is done by emergency medicine. And also speaks to these diagnosis lists. The final diagnosis for condition does not, in and of itself, determine the complexity or risks, as extensive evaluation may be required to reach the conclusion that the signs or symptoms do not represent a highly morbid condition. The potential for is just as significant as the final outcome. Presenting symptoms are likely to represent a highly morbid condition that may drive the MDM when the ultimate diagnosis may not be highly morbid. You talk to someone in the outpatient office sector, primary care, how many times they order D-dimers or troponins? Like, high sensitivity, like these troponins are ordered for ischemia or inflammation. We all know that. I know you know that. You order them for a reason, and part of these guidelines, part of this citation is emphasizing on the process, not necessarily the outcome, which is complete countergrain to the notion of a diagnosis list. Like, good news, you're not having a heart attack. Doesn't mean the cognitive effort and intensity that went into the evaluation should be undervalued. So how do we adjust for that? Well, one way we could support the work that we're doing beyond the diagnostic evaluation is documenting a differential. That really does go a long way in some of these conversations. I have a few charts here that give that have been used and are interesting. Here's a young patient that comes in with a, say, severe headache. Differential includes complex migraine, lower concern for CVST, RC, VS, or ischemic stroke, and then outline what's being ordered, for what reason, and why. Really clear to take that subjective area of the medical decision-making complexity section of the grid to make it really clear to what we're working up. I think we would all agree that an ischemic stroke, CVST, are life-threatening conditions, not acute chronic conditions or anything else like that. And that is used and is highly supportive. Documenting your discussions of management with your consultant, highly supportive. We do a good job of that, by the way. We do a really good job in emergency medicine. You talk to a hospitalist, GI, cardiology, orthopedic. In this vignette up top, you have a conversation with a neurosurgeon about a patient with a shunt issue. Like, yeah, we're going to do that. It's also helpful on these conversations about the way that the chart was coded. And then, of course, your independent interpretations. We often take a look at an EKG, an X-ray, a CT, and make a determination based off of that. You walk into any emergency department in the country, there more likely than not is at least one monitor showing an image of a film. And we've all been there where we've identified something that radiology did not. For the record, that radiology does a great job. But so does emergency medicine. And we know where the patient's point tender, we know where to look, and when we perform that work and document that work, not only can it be level defining, but it can be also supportive on the back end. Diagnosis coding isn't talked about enough. When you look at, and the reason I'm not going into like all of these diagnosis lists is because there are thousands of codes. They don't all overlap. Some are inclusion, some are exclusion. So I'm trying to find general themes to give practical considerations that you can take to your very next shift of when you're doing this. And with diagnosis coding, one of the common things that we see on these lists are unspecified codes. If we could get away from unspecified codes, that's even better. So an example, the most common areas that you see are abdominal pain, chest pain, and then weakness. That is a common, and headache, common theme when on these lists. It's incredible between unspecified abdominal pain and generalized abdominal pain. Unspecified abdominal pain and right lower quadrant abdominal pain. Anywhere that you have something that you could be specific, we should put it. You don't have to use one diagnosis, you could use several, and then the billing office will determine the sequencing and things like that of where to go from there. And it's totally appropriate to use a sign or symptom. So in a patient that you see, let's say they have chest pain, maybe they've got a history of diabetes, an abnormal EKG, like that. Those are things that could be put on the diagnosis line, and it's sort of the heart score, right? We're putting the heart score on the diagnosis line. And then think about the comorbidities and the risk stratification. By the way, not to even make this more, I'll say, interesting, that patient with a ruptured spleen was on a DOAC. Still an acute complicated injury. It's not that big a deal, people, I promise. It would have worked out just fine with a quick discharge. For traumatic injuries, we can include the mechanism of injury. Comorbidities. Clinically, when we speak to each other, we say history of diabetes, history of hypertension, history of hypercholesterolemia. That's all on the heart score as well. In the coding diagnosis rules, history of means occurred and is now resolved. So instead of history of diabetes, put diabetes. Assuming they still have the diabetes. History of lung cancer becomes lung cancer, unless it's been curative. It's a funny nuance within the guidelines themselves, but isn't discussed enough. If someone's on long-term anticoagulation, those are things that we could add to the chart to demonstrate the complexity of the visit that we're providing. Acute cystitis, for some reason, is, when you look at these lists, UTI is bad, acute cystitis is okay. It's an observation analyzing the data. And most of the cases in emergency medicine are initial, not subsequent. We're gonna keep it moving. So from the clinical lens, at the bedside, capturing those must-know MDM level-defining elements, like your independent interpretation, like your management discussions, like your Differential diagnosis, critical. Making a diagnosis, avoiding unspecified codes is highly supportive, and be as specific as you can. Signs and symptoms are okay to put in there because we don't often, in this job, we don't want to have, like if you find a specified diagnosis, that's usually not a good story. I mean, good news, we identified it, we're going to treat it. But if you have right lower quadrant abdominal pain and it's a negative evaluation, that's good for the patient, right? It's good for the patient. So what can we do as practice leaders to potentially avoid these algorithms? Well, one is just understanding your data and really fostering that relationship. That's really key and paramount. And then there are several layers. So there's the clinical perspective, and then there's the broader perspective of just understanding maybe it's a contractual issue, right? Maybe it's not a billing dispute, it might be a contractual dispute. Maybe there's a legal issue within that contractual dispute. There's multiple layers, but you can't understand things until you can see them. And understanding your data is one of the first places that you look. And I just reference, and they do a great job where I work clinically. I compliment them, I work very closely. They are fantastic. It's just really hard if you're coding like craniotomies and doing ECMO and doing all this big stuff to like notice that like, oh, that abdominal pain workup was downcoded from a 5 to a 4. Let's put a team on it to like work on it for the next 6 months. That'll end up with like a no pay, right? Like you understand the asymmetry of the situation, but putting that time and effort, asking for the data supporting it, and then for the billing office to really like put some effort into it when there's value, and understanding that there are contractual opportunities and potential legal opportunities that have been discussed, like real legal opportunities to solve these things. It may not be an issue of a true coding dispute. It might be something much different, and that's where that partnership really, really matters. Downcodes, delayed payments, no payments, common, pervasive, multiple specialties, the entire house of medicine, not one state. There's no single pattern you really have to follow and track and understand. The documentation on the front end could be supportive on the back end for the audit and audit defense. And then focused opportunities related to practice management is really understanding that data, having those conversations, and identifying those opportunities that exist. There's, for example, a large payer out there they'll negotiate with you. They'll say, oh, well, we're just going to keep downcoding you, but we could do a pay for precision program. That's great. We'll just give you level 4s for everything. And then it's just a business decision of what you want to do. And that's that. So there are opportunities out there. We can manage it from the local level all the way to the strategic level. Emergency medicine, as we open, evolves, innovates, and adapt. The insurance companies are bigger and bigger. Right? United Healthcare has their market cap is bigger than the GDP of several nations out there. And even though that might be true, it doesn't mean that we have to lose. There are opportunities and we will be okay. I'm very optimistic, so long as we are hyper proactive, but that's just emergency medicine. We have the fewest resources and we get the most done. I'm proud of the specialty. My contact information is here. I try to be as responsive as possible. Feel free to reach out with any questions. I'll take some questions, but just want to point out I'm 10 minutes early and I'm shaving down the time, getting everyone in this room to happy hour, which is where we want to be. Thank you very much, everyone.
Dr. Jason Adler with Downcodes and Denials, really diving into some of the games that are being played by the insurers as we continue to fight every day to ensure that we're getting appropriately compensated for the care that we are providing in the emergency department. I'm sure we'll have more from him in the months and years to come, secondary to just his sheer passion and knowledge associated with the RCM space, something that I think most physicians don't know enough about, but we definitely need to, as outside forces continue to try to whittle away at the emergency medicine foundation in terms of making sure that we have physicians in place and the ability to take care of our patients 24/7, 365. I welcome you to contact me, rstanton@acep.org, rstanton@acep.org. Also, please subscribe to the podcast on your favorite player. Leave us a 5-star review and share it with your friends and others that may be interested in the podcast as we continue to bring more great topics and discussions to the podcast. We've had a little run here of more of the discussion, or the lecture-based, as we've had several conferences, but we'll very soon be transitioning back to more of the interview style as we get into the season where I have the opportunity to attend conferences and make these interviews happen. So hope you'll join me, hope you'll stay with us, and I hope you'll spread the word. Until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
And in the silence, you will show me who you are.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
There. Quiet place, all
Yeah.
alone. Da, da, da.